The small intestine. For this lecture, we will be tackling about the approach to diarrhea, the different types of diarrhea, differentiation of small and large bowel diarrhea, the presentation of a small bowel obstruction, the benign and the malignant tumors of the small intestine. Diarrhea affects more than 1 billion individuals each year. Acute infectious diarrhea is one of the most common causes of mortality in developing countries, especially among children, contributing to 2 to 3 million deaths per year. The normal physiology of the small intestine and colon are to regulate the secretions and absorptions of waters and electrolytes. They serve to storage and subsequent transport of intraluminal contents. They also salvage some nutrients after bacterial metabolism of carbohydrates. Therefore, any alterations in the motor and sensory function of the colon will result in highly prevalent syndromes such as IBS, chronic diarrhea, and chronic constipation. An average of 9 liters of fluid will enter the gastrointestinal tract per day. A liter of the residual fluid will reach the colon. Stool excretion of fluid constitute only about 0.2 liters per day. The colon has a large capacitance and functional reserve. They recover up to 4 times its usual volume of 0.8 liters per day. They provide reabsorption and to compensate for the excess fluid delivery from the small intestine. In a fasting state, the motility of the small intestine is characterized by a cyclical event called the migrating motor complex. This serves to clear the non-digestible residue from the small intestine. Thereby, they are also known as the intestinal housekeeper. On an organized propagated series of contractions lasts an average of 4 minutes, occurring every 60 to 90 minutes, and usually involves the entire intestine. With food ingestion, the small intestine produces irregular mixing contraction of relatively low amplitude. Diarrhea is loosely defined as a passage of abnormally liquid or unformed stools at an increased frequency. For an adult on the typical Western diet, a stool that weighs greater than 200 grams per day can generally be considered diarrheal. Based on duration, a diarrhea can be acute if less than 2 weeks, persistent if it's between 2 to 4 weeks, and considered chronic if it persists for more than 4 weeks in duration. However, we have to differentiate an actual diarrhea from a pseudo-diarrhea, which the stool weight will only be less than 200 grams per day and associated usually with IBS, tenesmus, and proctitis. While fecal incontinence is defined as an involuntary discharge of rectal contents caused by anorectal and neuromuscular problems. More than 90% cases of acute diarrhea are caused by infectious agent. They are often accompanied by vomiting, fever, and abdominal pain, while the remaining 10% are caused by medications, toxic ingestions, ischemia, and other conditions. Most infectious diarrhea are acquired by fecal-oral transmission. In an immunocompetent person, the resident fecal microflora plays an important role in suppressing the growth of ingested pathogens. The disturbance of this microflora by antibiotics can lead to diarrhea by reducing the digestive functions or allowing the overgrowth of pathogens such as Clostridium difficile. Acute infection or injury occurs when the ingested agent overwhelms or bypasses the host immune and non-immune defenses, such as the gastric acid, digestive enzymes, mucus secretions, peristalsis, and suppressive resident flora. Now, who are the high-risk group of developing diarrhea? Topping the list are the travelers, especially to tropical countries, and persons who consume certain types of food during picnic, banquet, or in a restaurant. Common etiologic agents attributed to them are Salmonella, Campylobacter, Shigella from chicken, enterohemorrhagic E. coli from undercooked hamburgers, and Bacillus cereus from fried rice. In an immunodeficient person, opportunistic infection can also cause diarrhea, and common etiologic agents attributed to them are Mycobacterium species, cytomegalovirus, adenovirus, herpes simplex virus, protozoan, Neisseria gonorrhea, Treponema pallidum, chlamydia, enteric infection with Vibrio and Yersinia. For daycare attendees and family members, the commonly isolated etiologic agents are Shigella, Giardia, Cryptosporidium, and Rotavirus. While in institutionalized persons, they are prone to develop nosocomial infection. It is important to note that Clostridium difficile can affect or causes diarrhea even with no history of antibiotic use. The side effects of medications are the most common non-infectious causes of acute diarrhea, and the etiology may be suggested by a temporal association between the use and the symptom onset. Commonly attributed medications are antibiotics, cardiac antidysrhythmics, antihypertensive, NSAIDs, certain antidepressants, chemotherapeutic agents, bronchodilator, antacids, and laxatives. Associated with systemic compromise can also follow ingestion of toxins including organophosphate insecticides, amanita, and other mushrooms. Next, we go to the approach to the patient with acute diarrhea. Luckily, most episodes of acute diarrhea are mild and self-limited. However, there are certain conditions that needs further evaluations. They are for patients with profuse diarrhea and dehydration. If a patient passes out grossly bloody stool, if they have fever of 38.5 degrees centigrade, or if the diarrhea persists for more than 48 hours without improvement, if there's a history of recent antibiotic use, if there is a new community outbreak, or if the diarrhea is associated with severe abdominal pain in patients over 50 years old. All elderly patients more than 70 years old are required to undergo further evaluation. So do immunocompromised patients. The cornerstone of diagnosis in severe acute infectious diarrhea is microbiologic analysis of the stool. Workup would include cultures for bacteria and viral pathogens, direct inspection of the ova and parasites, if they are present, and immunoassays for certain bacterial toxins, viral antigens, and protozoan antigens. If the stool studies are unrevealing, a flexible sigmoidoscopy with biopsy and an upper endoscopy with duodenal aspirates and biopsies may be indicated. Structural examination by sigmoidoscopy, colonoscopy, or abdominal CT scanning would exclude IBDs or with suspected infectious causes of acute diarrhea. Fluid and electrolyte replacement are the central importance to all forms of acute diarrhea. Oral sugar electrolyte solutions, such as sport drinks or designed formulations, should be instituted promptly with severe diarrhea to limit dehydration. Profoundly dehydrated patients, especially infants and elderly, would require IV rehydration. Moderately severe, non-febrile, and non-bloody diarrhea, an anti-motility and anti-secretory agents such as loperamide can be useful in adjunct to control the symptoms. However, they are not to be used with febrile dysentery. The judicious use of antibiotics is appropriate in selected instances, such as elderly patient, immunocompromised patient, patient with mechanical heart valves, and those with recent graft surgery. This is a flow chart that shows how we approach a patient with diarrhea. First, we get the good history and physical examination. And then we determine whether the likely to be non-infectious or the likelihood to be infectious. If they're likely not to be non-infectious, then we just evaluate and treat them accordingly. However, If they are likely to be infectious, then we have to assess whether they are mildly dehydrated, moderately dehydrated, or severely dehydrated. In all three groups of patients, all of them have to institute fluid and electrolyte replacements. For the mildly dehydrated patient, after instituting IB and electrolyte replacement, we can observe them. If they resolve, then we discharge the patient. However, if the condition persists, then we might need to do a stool microbiologic studies to identify the pathogens. Once identified, we can give specific treatment. If there's no specific antigen that pathogens that are detected, then we can give empiric treatment and further evaluation. For the moderately dehydrated patient, again, after instituting IV fluid and electrolyte replacement, we try to assess or if the patient has fever, we try to do some assessment if their blood is bloody or there are lots of fecal leukocytes, and whether or not these patients are immunocompromised or elderly. If they are yes, then they all need to undergo stool microbiologic studies and again to identify the pathogens. However, if there is none of these symptoms as mentioned, then we can give antidiarrheal drugs such as loperamide. And if it resolves, then we can discharge the patient. However, if the condition persists, they also need to undergo stool microbiologic studies to identify the pathogens. Once pathogens are again identified, they can be treated specifically, and if there's no pathogen that are identified, then we can give empiric treatment and reevaluate again. For those patients who are severely incapacitated because of severe dehydration, after instituting fluid and electrolyte replacement, they are all to undergo stool microbiologic studies to identify, of course, the pathogens. Once identified, again, give specific treatment. Once there's no pathogen identified, then we can give empiric treatment. Now, this chart will show us the differentiation of a small and large bowel diarrhea when it comes to volume. The small bowel has a larger volume compared to the large bowel. The color, the small bowel will give you a lighter color of stool, while the large bowel will give you a darker color. As to smell, small bowel will be very foul in smell. As to the nature, small bowel will give you a greasy stool, and large bowel will give you a mucinous and jelly-like stool. Type, usually small bowel give you watery diarrhea and large bowel give you a mucoid diarrhea. Okay. The presence and absence of RBC in stools are very rare during small bowel disease, and they are common during large bowel. Bleeding coming from the small bowel will manifest as melena, while bleeding from the large bowel will manifest as hematochezia. Next, we go to chronic diarrhea. Diarrhea that lasts for more than 4 weeks warrants evaluation to exclude serious underlying pathology. In contrast to acute diarrhea, most of the causes of chronic diarrhea are non-infectious in nature. The classification of chronic diarrhea by pathophysiologic mechanism would facilitate a rational approach to their management. The different types of chronic diarrhea could probably be secretory, osmotic, steatorrheal, inflammatory, dysmotile, factitial, or iatrogenic. Secretory causes are due to derangement in fluids and electrolyte transport across the enterocolonic mucosa. They are characterized clinically by watery, large volume fecal outputs that are typically painless and persist with fasting. Medications. Side effects from regular ingestion of drugs and toxins are the most common secretory causes of chronic diarrhea. Habitual use of stimulant laxatives such as senna, cascara, bisacodyl, and castor oil. Bowel resection, mucosal disease, or enterocolic fistula results in a secretory type of diarrhea because of inadequate surface for reabsorption of secreted fluid and electrolytes. Hormones. Metastatic gastrointestinal carcinoid tumors, or rarely the primary bronchial carcinoids, may produce watery diarrhea alone or as part of the carcinoid syndrome that comprises the episodic flushing, wheezing, dyspnea, and the right-sided heart failure. Gastrinoma is one of the most common neuroendocrine tumors, most typically present with refractory peptic ulcers, but diarrhea occurs in up to a third of the cases and may be the only clinical manifestation in 10%. Osmotic causes of chronic diarrhea. Osmotic diarrhea occurs when ingested poorly absorbable osmotically active solute draws enough fluid into the lumen to exceed the reabsorptive capacity of the colon. Examples of osmotic laxatives are the magnesium-containing antacids. Carbohydrate malabsorption due to acquired or congenital defect in the brush border disaccharides and other enzyme leads to osmotic diarrhea with a low pH. The most common cause of chronic diarrhea in adults is lactase deficiency. Steatorrhea is defined as a greasy, foul-smelling, difficult to flush diarrhea with weight loss and nutritional deficiency. Stool fats are noted to be more than 7 grams per day. The main causes of steatorrhea are intraluminal maldigestion, which results from pancreatic exocrine insufficiency, which occurs when more than 90% of the pancreatic secretory functions are lost. Chronic pancreatitis, usually due to ethanol abuse, is the most frequent causes of pancreatic insufficiency. Celiac disease can give malabsorption. They are gluten-sensitive enteropathy, while lymphatic obstruction can result from trauma or tumors or cardiac disease. Inflammatory causes of chronic diarrhea are generally accompanied by fever, pain, bleeding, and other manifestations of inflammation. The mechanism of diarrhea are exudation, fat malabsorption, disrupted fluid and electrolyte absorption, hypersecretion or hypermotility from release of cytokines, and other inflammatory mediators. The marker of inflammatory diarrhea is the presence of leukocyte in the stool. Examples of inflammatory bowel disease are Crohn's and ulcerative colitis, microscopic colitis such as collagenous or lymphocytic colitis. Other causes of inflammatory diarrhea are primary immune deficiencies, eosinophilic gastroenteritis, radiation enterocolitis, and graft versus host diseases. Dysmotility and factitial causes would include irritable bowel syndrome, hyperthyroidism, diabetic diarrhea, carcinoid, Munchausen syndrome, eating disorders. Now, how do we approach a patient with chronic diarrhea? The history, physical examination, and routine blood studies should attempt to characterize the mechanism of diarrhea, identify diagnostically helpful associations, and assess the patient's fluid electrolytes and nutritional status. A family history of IBD or sprue may indicate those possibilities. Physical findings may offer clues such as thyroid mass, wheezing, heart murmurs, hepatomegaly, masses, and mucocutaneous abnormalities. This slide shows the approach of a patient with chronic diarrhea. And also with this slide. Now, how do we treat a patient with diarrhea? Well, it depends on the specific etiology, and it may be curative, suppressive, or empirical. If the cause can be eradicated, treatment is curative, as with resection of a colorectal cancer. Diarrhea can be controlled by suppression of the underlying mechanism, like elimination of dietary lactose for those patients with lactase deficiency or elimination of gluten for those patients with celiac sprue. Glucocorticoid or other anti-inflammatory agents for idiopathic IBDs. Empirical therapy may be beneficial, like mild opiates such as diphenhexylate or loperamide can often be helpful. For all patients with chronic diarrhea, fluid and electrolyte repletion is an important component of its management. Small bowel obstruction. They usually present as a poorly localized intermittent periumbilical supraumbilical colicky pain. As the intestine progressively dilates and loses muscle tone, the colicky pain may diminish. A superimposed strangulation obstruction pain may extend to the lower lumbar region if there is a traction on the root of the mesentery. The colicky pain of colonic obstruction is of lesser intensity and is commonly located in the infraumbilical area and may often radiate to the lumbar region. Small and large bowel blockage occur because of adhesions, benign or malignant tumors, volvulus, intussusceptions, or inflammatory diseases like Crohn's. For tumors of the small intestine, small bowel tumor comprises less than 3% of the gastrointestinal neoplasm. They should be considered in the differential diagnosis in the following situation: recurrent unexplained episodic or crampy abdominal pain, intermittent bouts of intestinal obstruction, especially in the absence of IBD or prior abdominal surgery, intussusceptions in the adults, evidence of chronic intestinal bleeding in the presence of negative conventional and endoscopic examinations. For the tumors of the small intestine, a careful small bowel barium study should be considered because infusing barium through a nasogastric tube into the duodenum may improve the diagnostic accuracy. There are also another good alternative to evaluate the small bowel tumors would be capsule endoscopy. For the benign tumors of the small intestine, benign tumors of the small bowel are difficult to predict on clinical and radiologic grounds alone. Symptomatology of benign tumors is not distinctive. The most frequent symptoms are pain, obstruction, and hemorrhage. They are usually discovered around the 5th and 6th decades of life. They are more on the distal than the proximal of the small intestine. Adenomas would include those of the islet cells and the Brunner glands, polypoid adenomas. Islet cell adenomas are occasionally located outside the pancreas, while the Brunner's gland adenomas are not neoplastic but represent a hypertrophy or hyperplasia of the submucosal duodenal glands. Polypoid adenomas. They consist about 25% of the benign small bowel tumor, may represent a single polypoid lesion or commonly known as the papillary villus adenomas. In Gardner syndrome, they are pre-malignant adenomas that are found in the duodenum. For the Pew-Jeger syndrome, there are multiple polypoid tumors throughout the small intestine, but occasionally found in the stomach and the colorectum. For the leiomyomas, they are neoplasm that arise from the smooth muscles component of the intestine. Ulceration of the mucosa may cause gastrointestinal hemorrhage. They manifest as cramping, intermittent abdominal pain. For the lipomas, they occur with great frequency in the distal ileum and at the ileocecal valve. Their characteristics are they are radiolucent in appearance, they are intramural and asymptomatic, but occasionally causes bleeding. For the angiomas, they are not truly neoplasm. They are lesions that are important because they frequently cause internal bleeding. They take the form of telangiectasia or hemangiomas. Multiple intestinal telangiectasias occurs in a non-hereditary form confined in the gastrointestinal tract or part of the hereditary Osler-Rendu-Weber syndrome. Vascular tumors takes the form of isolated hemangiomas, most commonly found in the jejunum. The best procedure for evaluating this type of lesions are angiography, especially during bleeding episodes. Next, we go to the malignant tumors. Malignant tumors are rare in the small bowel. Malignancies occurs in patients with long-standing regional enteritis, celiac sprue, and AIDS. Frequently, they are associated with fever, weight loss, anorexia, bleeding, and palpable abdominal masses. Ampullary carcinoma arise from the biliary or pancreatic ducts. Next, we go to adenocarcinoma. They are the most common primary cancer of the small intestine. They account for 50% of the malignant tumor. They occur in the duodenum, proximal jejunum, where they tend to ulcerate or obstruct. Diagnosis is best made by endoscopy or biopsy under direct vision. Treatment of choice, of course, is surgical resection with suggested postoperative adjuvant chemotherapy, which would follow the treatment pattern of management of colon cancer. Lymphomas. Primary intestinal lymphomas are neoplasms that are non-Hodgkin's lymphomas, which have a diffuse large cell histology and are of the T cells. They account for 20% of the malignancy of the small intestine. They usually involve the ileum, jejunum, and duodenum in decreasing frequency. Lymphomas diagnosis needs a histologic confirmation in a clinical setting in which palpable adenopathy or hepatosplenomegaly are absent and no evidence of lymphoma on chest or CT scan. Peripheral blood smear, biopsy, bone marrow aspirations. However, secondary lymphomas are involvement of the intestine by a lymphoid malignancy extending to and from involved retroperitoneal or mesenteric lymph nodes. For carcinoid tumors, they arise from the argentaphine cells of the crypts of Libercon. They are found in the distal duodenum to the ascending colon. Most are asymptomatic, but invasion and metastasis can occur. More than 50% of the intestinal carcinoid are found in the distal ileum. Leiomyosarcomas are often greater than 5 centimeters in diameter, may be palpable on the abdominal examinations. Most common symptoms would include bleeding, obstruction, perforations. Such tumors should be analyzed for GIST, Gleevec, Stutent, and Stirvaga. And that's all. Thank you for listening.